Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. John Leizman from Premise Health about advanced primary care, investing in happier and healthier patients. Let's get started.
Well, Dr. Dan, it is good to see you.
It's good to see you, Faisel. Crazy world.
It is a crazy world. My God, that is a very true statement. Dr. Leizman, it is so good to see you as well. It was great to meet you last month at the PCFA meeting at the National Press Club.
Well, it's nice to meet you too, Faisel. Thank you for having me on the podcast today. It's an honor and a privilege to be with you and Dr. Dan.
You know, I'd love to get this kicked off with a conversation I had with my cousin. He's an attorney, and they're expecting a new baby. And he's in that phase of life where he's looking at benefits and all this stuff. And I was telling him that now, for a family of four, it costs over $30,000 a year for health insurance benefits. And it wasn't that long ago where it was like $3,000 or $4,000 a year. So what are employers doing to help control these costs while still offering adequate coverage?
I think they're doing anything and everything they can. They're keenly aware of the problem. And if you look at the statistics right now, $25,000 to $30,000 for family coverage, and according to Business Group on Health, it's going up 7 to 8% a year. Over the past decade or so, costs have increased 50%. So it's not sustainable. And on top of it, Faisel and Dr. Dan, it's not working. You know, I was at the Primary Care Collaborative conference in Washington, D.C. last week, and there was this common refrain, which is in the United States, we're paying twice as much for healthcare as our counterparts are in OECD, Western countries, and our life expectancy is 5 to 7 years shorter. So I think employers are becoming increasingly aware of this because it's affecting their bottom line. It's affecting their workforce's health. They want to do everything they can. In the case of Premise, we partner with employers and unions to bring healthcare to their workers. And we do this through onsite clinics and near-site clinics. We also operate our own 24-hour, 7-day-a-week virtual health platform. And this is one of the ways that employers are making some inroads. It's by addressing and prioritizing primary care, which we know is one of the few things in the healthcare system that actually produces superior outcomes, brings down costs.
That's a great point. I think a lot of times employers view healthcare cost as a fixed cost and there's nothing they can do about it. How do you get them to view it rather than just a transactional expense as an investment in the health and well-being of their staff? So not only is it about covering their sick benefits, it's about having a healthier staff that comes to work every day. So, right? I mean, it's not just, there's so much more to wellness than just absence of sickness.
You're so right, Dr. Dan. And I think there are multiple levels to this. You know, our value proposition premise is to deliver high quality, cost-effective care in an experientially rewarding manner. And from the employer perspective, you know, there's a lot of tension in the financial offices about the cost increases in healthcare. But I must tell you, throughout my career, when I've sat down, whether it's with the chief financial officer or somebody in human resources, almost uniformly, they concern themselves about their employees' well-being. They want their employees to be healthy. It's the right thing to do. They know it. They're compassionate people. They're no different than anybody else. And they're also mindful of the fact that there can be distractions for people. We all live lives that are filled with challenges, a number of domains, whether that's housing and financial issues, or if it's raising children or health problems, which might emerge. And of course, our generations too could come into play. So I think that employers are very much attuned to it, and they look at this through a number of lenses. One is first just access, and they recognize that access to care, access to primary care can be a challenge. They recognize that there's a cost burden, not just for the company, but what we're seeing oftentimes, particularly with high deductible health plans, is that American workers are challenged in that they're faced with struggles just by paying for healthcare bills. So they avoid care rather than to seek care, which is an investment in their own health.
Right. And it's not only avoiding the cost of care, it's avoiding taking time off from work. So you help solve that solution in a lot of your locations, right? I mean, it's on site, near site, therefore they can come see you and not miss an entire day or day and a half from work.
Yes. And so, kind of from the population perspective, Americans have chronic diseases. We all know that, whether it's chronic asthma that can keep you from going to work every day, or if it is migraine headaches where you might be able to go to work, but you aren't necessarily as productive. And by addressing some of these illnesses, by providing convenient access to quality care and getting to the underlying cause, we can help employees be more productive. That's one side of it. The other is just the simple experience that we all have, which is if you call up because you're not feeling well to get an appointment, it can be months wait just for your doctor. So the example I frequently use is if you happen to have signs or symptoms of a urinary tract infection on Tuesday and you call your physician and they can't see you until Friday, and in truth, it's more like 2 weeks from Friday. In today's world, it doesn't do you a whole lot of good on Wednesday and Thursday. So one of the values that on-site clinics oftentimes bring to employers is somebody has those symptoms and it's not calling off of work. It's not scheduling that appointment, which might be at 10:30 in the morning, which means it doesn't even justify waking up and going to work before you have the appointment and waiting in the doctor's office for 45 minutes before you're seen, and you're in the exam room for 45 minutes and the doctor's in there for 5. Then you got to go get the prescription filled. It's already past lunchtime and you're hungry. So, maybe you end up taking the whole day off of work. Whereas in an on-site clinic, you can literally just go down maybe 2 or 3 floors in the building. You can go to the clinic. You can be seen by the provider right there same day. And then oftentimes, depending upon the diagnosis, you're walking out with the prescription medicine in hand. So instead of it being a half day or a whole day affair and a lot of aggravation on the telephone in the front end trying to get the appointment, everything is condensed. Individuals are getting that access to treatment a lot more quickly than they would elsewhere in the community. And that brings with it productivity.
Thanks for explaining that, Dr. Leizman. For the students and maybe the residents who are new to this and they know about traditional health insurance, if you could help discuss the shift to more of this integrated employer-sponsored option and how you're able to help save considerable amounts of money.
Yeah, absolutely. So we work outside of traditional fee-for-service, and we work on a cost-plus basis where we have direct contractual relationships with employers, unions, and health plans. And by that arrangement, their covered lives are eligible members for our services. So in the case of an employer who we have a clinic on site with, everybody who is eligible, who works at that campus and perhaps elsewhere in the community who's part of that employer benefit stream, and that could be dependents, so it could be spouses and children or other workers who might work remotely, they're eligible to come into our clinic. Because we operate outside of traditional fee-for-service, that means we're not focused on volume like you would expect in a traditional community primary care practice. That allows us to spend more time with patients when they come in and to attend to their holistic needs.
So you've integrated everything from the behavioral health to primary care, even you mentioned about the pharmacy side. What's the biggest challenge with making that integration work? Like how does that benefit the employer and the employee?
Yeah, so in premise, Faisel, we take somewhat of a unique view to advanced primary care. It's both what I would say a construct as well as a philosophical approach. And on the construct side, the model is it's primary care. So think of traditional patient-centered medical home, integrated with behavioral health, integrated with pharmacy, care management, and care navigation. And the trick is really to have those integrated services, which means we have premise health team members providing team-based care to individuals, both who are coming into the clinic and also the ones who are engaged members, but might not even come into the clinic because we're searching registries to see if there are any deficiencies or care gaps. So we can have warm handoffs. Somebody sees the primary care physician and that physician is worried or suspects, maybe makes a diagnosis of anxiety. Well, we know that the best results come from tandem treatment, pharmacotherapy, plus behavioral health therapy. There can be a warm handoff where that primary care clinician not only schedules the appointment, but actually walks over, introduces the behavioral health therapist. It's a warm handoff, helps to build likelihood of adherence and follow-up. And then maybe a prescription is also written. That individual might walk right across the hall to one of our pharmacies and might pick up the prescription that day.
Yeah, I mean, you're improving access. You're making it simple for the employees, especially the on-site facilities. I mean, the near-site ones, how far away are they for the employers?
So it depends. And there are a couple of blends. So on-site can be right in the building where an employer is. A near site, I would say, is in two flavors. So if an employer has a campus, it might actually be on the campus, but not necessarily in the building. And then we have near site facilities, which are in the community in proximity to where a significant proportion of employees either work or live.
What I mean, this just seems like a no-brainer to employers. Like, I don't understand why there's hesitation with some
Well,
employers to adopt this.
well, I think, and I don't know, correct me if I'm wrong, a lot of times the employers, the broker for the third party administrator that's handling the benefits as a relationship, and they just keep telling them that the costs are going up and up and up. And there's this thinking that the third party administrators, the insurance companies handling the benefits, are actually interested in lowering the cost of healthcare, but they generally get, because of the medical loss ratio, they tend to get a cut out of it. So while every year they want to manage the cost to the MLR, next year they're actually better off if costs go up this year, because then they're getting a 10 or 20% cut of a larger number the next year. But I mean, John, you correct me if I'm wrong about that. That seems to be some of what goes on in the employer space.
That's absolutely correct. Now, the flip side of that is we're a carve out from traditional plan, and employers are wisening up and they're frustrated with the health system. So interestingly, our roots at Premise Health go back roughly 60 years. And
Wow.
What I think has kept us nimble and has kept us in business and relevant is we've really responded to what the employer needs and the marketplace is. So 6 decades ago, it was steel mills and coal mines and providing traditional occupational health services, including things like work injury care and required surveillance screening, pre-placement exams. That's still very much a part of our business. But over the decades, particularly as healthcare costs increased, employers have realized they need to do more. And it started out with just keeping people at work. So if you are a plant in a relatively rural area where there are access issues, if you can have some urgent care services or acute episodic services that go alongside the occupational health services, well, then the employee doesn't have to take the day off of work, to your earlier question, Dan, or they don't have to travel 30 miles. Well, as things continue to evolve, it became wellness and screenings to detect illness early on when possible. And then it became primary care services. And now, as I mentioned before, it's full service primary care integrated across this platform of services.
Wow. Yeah, especially now with like all the high deductibles that weren't there. It's just become part of the norm. So I just don't understand why there's still so many employers who are hesitant to just make the transition.
So the good news is we have seen increasing uptake of our type of services, these direct to employer services, on-site clinics, over the past decade or so. And I can share with you, we are seeing increasing activity still, an increasing pipeline of interest from large employers, from unions, from health plans, because there is growing recognition. This is the optimistic part of some of our healthcare system and dynamic right now. There is increased recognition of the value of primary care, and employers see this is one way that they can drive individuals into primary care relationships. derive some of those superior outcomes, whether it be the clinical measures that we study so closely, or if it's financial, or if it's convenience.
Yeah,
So,
some of the savings are right away. I mean, I'm sure they see it the first year, but as you know, as the relationship is there, I mean, I'd love to share some of the percentages people can expect to see in savings within 2 to 3 years.
So I can share some data with you, and I'm happy to do. So, at a high level, your intuition is right. The benefits accrue. And the reason why the benefits accrue is we all know when a patient comes into the office and you make the diagnosis of hypertension and take their blood pressure down from systolic 164 to 130, it's not the next day that you're preventing the stroke. It's not the next day that you're preventing the chronic kidney disease or the myocardial infarction. Those benefits accrue over time. As individuals get healthier, as they increase their activity levels, as they lose weight, and they become more engaged, or they get better control, behavioral health or mental health concern, we see increasing benefits. So some of the data and some of the statistics, we ran a study across our book of business that was over 200,000 premise health attributed patients. And this was with 26 organizations. It was across geography. We're in 45 states and Guam, and it was across industry. And with that, we saw close to a 30% reduction in overall healthcare costs. We ran the study a year before, it was 24%. And I think we're going to continue to see gains. The question is, how does this work? How do we do this? So interestingly, so that 30% decrease in overall costs is reflective of a 20% increase in preventive, routine, and mental health visits. That's offset by 17% reduction in emergency department visits and 52% reduction in hospitalizations.
and I mean, at some level, that's probably saving lives. I know you probably haven't studied it at that point, but we've talked a few times on the podcast about the risk that anybody goes getting admitted to the hospital. And hospitals do really good work, but yet they take care of a lot of patients. And so there's a lot of opportunity for things to happen when you're in the hospital. So you're always safer to be at home if you don't need to be in the hospital. So 54% reduction in hospitalization that's huge, right? Now, I guess you charge a large copay for people to come get your services, right? You probably charge $100 or $200 a visit for them to come see you, right?
It depends on the organization's underlying plan and design, but the idea is to have benefit design that incentivizes primary care. So we're big proponents of zero cost to access primary care and routine care and preventive services, and to encourage and drive individuals into those relationships because we know it works. So the more individuals that are covered by a plan, the more employees that an employer has, or the more members on a union's plan that come in, the more good that we're doing on the individual basis, and also for the plan, the more we stand to benefit.
We got to reduce all these administrative barriers. I mean, this is so. How can some policy changes streamline this whole process, make it easier for employers to provide care?
So there is some legislation pending as part of the Reconciliation Act that would allow for individuals who are covered by HSA to be in high deductible plans to access services without cost. And we're big advocates and proponents of that. That is our primary policy issue right now, is we want individuals to be able to access those services regardless of what type of plan they're on, or regardless as to whether or not they have a
Right, because I mean, I know when I was a medical student, my dad was a mail carrier, and that was before the ACA. So when I got to be, I forgot what age, 25, 26, I had to come off his insurance, and I had a year. And at the time, the medical school had a pretty good student health plan, and I was able to go to the AMA and buy a high deductible plan for almost nothing, and I went uncovered for about $10,000 in the middle, figuring that if something happened, I wasn't going to live a life of poverty because I could undertake that $10,000 debt. And that's really what a lot of people can't afford to pay a $400, if they have a $400 car repair they need to do, it's a financial crisis. So allowing them to have that high deductible plan, but have the primary care to help them keep from getting sicker and sicker and falling into some catastrophic illness seems to be a really smart way to arrange healthcare benefits.
We think so. And Faisel, following up on your question regarding policy, there are a couple of other issues that I know many of us are concerned about, one of which is workforce. And anything to encourage and to propagate the pipeline of primary care physicians is something which we are very vested in. We think benefits patients. We think it benefits the American public and ultimately the taxpayer as well. We do borrow from some policy in strategic planning. I'm thinking about at the state level and some of the work that Milbank has done. I referenced earlier some of the OECD countries that have more favorable spend profiles and life expectancy profiles. Well, those countries tend to allocate a greater proportion of their overall healthcare spend to primary care. In the United States, we're under 5%, whereas in many of these other Western developed countries, it's between 10 and 15%. So we know that formula works. One of the things that we often encourage our employers and unions and partners that we work with is measure your primary care spend and let's target getting to that 10 to 15% level.
Yeah, I mean, I know there are a few states working on that.
Doubling or tripling.
Yeah, I mean, I'm on a committee for the state of Virginia looking at should we set a target spend for primary care. And it's interesting because, right now I think the average spend in Virginia is 4%. And it wasn't specifically to Virginia, but I heard somewhere that the average spending on emergency room visits was up to about 6% of the healthcare spend. And so spending more money in the emergency departments and it's not like everything going in the emergency department is the major trauma. A lot of what they're doing is people can't get into primary care. They're getting frustrated and they're going to the emergency room. Or the example you gave earlier, you don't treat the UTI on Tuesday and by Monday it's pyelonephritis. And now they're not only in the emergency room, they're in the hospital bed or maybe in ICU on IV antibiotics because of a delay in treatment.
Dr. Dan, some of these payment mechanisms are so inverted, it's baffling. I learned from Primary Care Collaborative, we spend as much or more on dermatology than we do on primary care. The typical cost for a primary care visit is in the neighborhood of $250, whereas for a gastroenterology visit, it's over $1,000. And we know if you invest money on the front end, not only do we oftentimes have healthier and happier patients, but it's also more cost efficient.
Yeah, I love hearing physicians, making these transitions to healthcare leadership. For the students and the residents who are listening, like what was the moment that helped shape your decision to get into healthcare leadership?
There are a few salient points I can think back on. Faisel, I don't know if there was any one, but I was attracted to having a broad purview of the health system and thinking about things broadly rather than be narrowly focused. I think that was part of the attraction for me to enter residency in family medicine. I also vividly remember when I was in residency at Case Western Reserve University Hospitals, which it catered, that practice catered largely to an inner city population. And each residency class throughout the course of their tenure had a project where they were supposed to do some sort of a study or some sort of a semi-research based initiative. And classes may have run surveys. They may have looked at engagement strategies. My class of 8 opted to do a survey of health, essentially a health needs assessment of the local community. And there was one team that drew up the survey. I was assigned to the crew that had to go into the inner city and actually interview people. And I was a little bit apprehensive. Having grown up in the Cleveland area, I knew that there were neighborhoods frankly, that I didn't frequently encounter. And we went to a grocery store and we interviewed people as they were at the checkout counter and as they were leaving the store. We asked them if they would spend a few moments with it. And the question was simple. What is the most important health concern for you and your community? And I knew in the textbook that the top 3 killers at the time were heart disease, cancer, and stroke. And the answers we got were crime, money, and drugs. And that taught me that there is a bigger picture to just what's happening in the exam room. And some of these things need to be thought about holistically in addition to everything that's in the textbook.
Absolutely. I think we've heard it said many times that only about 10% of health outcomes are related to what we do with the prescription pad, and 80% have something to do with social determinants of health, our lifestyle, or where people are living and working. And so you make a great point there.
We found that that's very true, and we're attentive to that. Earlier on, I mentioned that our view of advanced primary care is both as a construct as well as a kind of philosophical approach. The philosophical approach is high quality, cost effective, person centered care with a focus on lifestyle, with a focus on behavioral change, attention to cultural competency, and very importantly, helping individuals identify and overcome barriers that they have to living their healthiest lives. So oftentimes these include things like transportation, housing, it could be intimate partner violence, it could be substance uses. Those 80 to 90% of the things, Dr. Dan, that we do not necessarily think about as being the province of the exam room, but are so important to whether or not somebody is able to adhere to recommendations or even to show up for their appointment.
Yeah, I mean, it's that makes a huge difference. And what did you find talking to the people in the grocery store is they're sort of people too, right? They have the same worries and concerns that we do, and they want their family to be healthy and happy the same as we do.
Absolutely. And it humanizes what we do. It helps to recognize how life is lived, not just what we see oftentimes going from exam room to exam room. And those individuals who we talk to that day have real world important concerns, and they're confronted on literally a moment by moment basis of what's most important to them, not necessarily or exclusively what we might find in the textbook. I've come to learn that medicine is much about our patients as it is about the disease and the conditions that they might have.
Right. I agree. Sometimes we like to ask our guest if you had a magic wand and could make 1 or 2 changes in the U.S. healthcare system that you would like to leave as a gift to the healthcare system when time comes for you to put down your stethoscope, what would those wishes be?
I think there are 2, and they're related. At the expense of repetition, a robust primary care system would be tops. Secondly, when I think about the students and residents, and I know that's come up a couple of times in our conversation, I would like them to have the excitement and the enthusiasm about a prosperous career. And when I say prosperous, I mean across the spectrum, certainly not just financially, but that psychological income that's derived from connecting with a patient. At the end of the day, when you look in the mirror, knowing that you did the best you could to help somebody, to appreciate some of those circumstances of how life is best lived. And, coincidentally, I think if we were able to arrive at that state, I think we would see more of an appeal of of primary care for many young and aspiring physicians.
Well, Dr. Leizman, thank you so much for taking the time and your insights today.
Well, thank you so much. It's been a pleasure.
What are your thoughts on advanced primary care, investing in happier and healthier patients? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.